Having a beautiful day, and we at Micronova welcome you all to this webinar, which is actually focused on the multidisciplinary care for peripheral neuropathy, its approach and the role of Neurotronics. I welcome you all on behalf of my boss, Mr. Herman Sharma, who is actually the president of Micro Labs. And for today's webinar, it's actually a platform of sharing knowledge and the impact of the knowledge we're actually sharing in the treatment of neuropathy and other advancements so far. But before we move on, we actually like to introduce ourselves. And for some of you that are joining us for the first time or getting to hear about Micronova, we actually want to share with you who we are or what Micronova Pharmaceuticals is all about. So I welcome you all.
The first speaker.
Okay. The university, I believe.
No, it's a Micronova.
Okay.
They are discussing a neuropathy.
Oh, okay.
They have a product for neuropathy, so they invited me as the endocrinologist
Okay.
and then a neurologist.
Micro Labs, this is where action results in better life with every activity we do, both in the clinics, in the institutions, and all that. It's actually to be able to impact a result leading to better life. Our vision to be regarded as the state-of-the-art pharmaceutical company in terms of quality and product satisfaction. Also to provide medicines at competitive prices anywhere in the world. So in talking about Micronova, we actually have a leading position in selected therapeutic areas, looking at cardiology, diabetology, ophthalmology, dermatology, pain and analgesics. So also gastroenterology, acute therapy and neuropsychiatry therapy areas, and other molecules. We also have the state-of-the-art manufacturing facilities as approved and by other regulatory bodies. As we can also see for R&D centers with capabilities of ANDAs, DMFs, and NDDS, which are actual regulatory bodies. For Micronova, we actually have this global impact. And looking at this global impact, we have a huge global footprint when it comes to the pharmaceutical industry. We're well poised to achieve in the medium-term status, being referred as a big generic company. Because for Micronova, it's actually that one-stop shop where you have innovative generics, building critical mass in existing markets and developing business in new markets like the US, East Europe, North Africa, South and Central America. For Micronova, we have 15 world-class manufacturing facilities dedicated especially for molecules like cyclosporines, bacter-lactam, immunosuppressant therapies, mentioned in regulatory bodies as can be listed. Micronova actually boasts a robust range of over 520 brands, spanning across all areas, and that will actually be referred as a big generic pharmaceutical company. Well, we started operations in Nigeria as Micronova in 2011. We registered over 132 products with NAFDAC, and we still have more in our pipeline. Products are actually available in all major pharmacies, and we have a strong team of over 200 sales and marketing professionals across Nigeria, and we are focused on quality products with highest efficacy at affordable prices. As I've mentioned before, for Micronova, we started with 5 products, but we've increased to 132 products, operating 5 divisions with different specialties. In some of our leading over-the-counter, over-the-ethical brands, we have things like our EcoSlim, Zonadine, brand of fexofenadine, Rooster, our Febuzostat brand, and Micronova, our Neurotonic, Micronac SR, and NSAID, cephalosporin, our Cephadox, is our brand of cephalosporin, and Teleb, our brand of levofloxacin of different SKUs. For Micronova, we actually got awards as the most trusted brand in Nigeria, and they also received the award of the National Quality Order of Merit Awards in 2023. We also listed among the African 10 most valuable brands for 2023. And with this, I'd like to say thank you very much, and I welcome you to this webinar. But in going forward, as I welcome you all to this webinar, and I've mentioned before that our aim is actually to share knowledge and also exploring latest advancements in the treatment of neuropathy. In this team today, to guide us through this program, I have with me is actually my able business development manager, Dr. Joel, who also will be anchoring this program. I would also want to introduce the moderator of the day. And this is somebody that has actually elevated my status by allowing me to actually introduce him. This is somebody that I respect so much, and this person happens to be the Vice President 3 of EMSON, that's Endocrine and Metabolic Society of Nigeria, the Chairman Residency Training Committee for Rivers State University Teaching Hospital. He also happens to also be the head of department for internal medicine of Rivers State University and also Rivers State University Teaching Hospital, Rivers State. And join me as I welcome Professor Ibitro Kemi Faye Korubo, who happens to be a consultant endocrinologist and diabetologist. I welcome you, sir. He will be doing the honors in introducing our special guest for today. You're welcome, Professor Korubo.
Good afternoon, everybody. Good afternoon, Harriet. I don't know if I'm audible.
Yes, you are, sir.
Okay, let me welcome everybody to today's program. And think that the topic was well thought out, and we have the right people to throw more light into how to care for patients living with diabetes that have neuropathies. You know, usually most people would expect that once you say a patient has a neuropathy, and then you're going to be dealing with either tingling sensations or numbness. But remember that patients with neuropathy may also have features that affect their cardiac function and other functions, erectile dysfunction, and a few other things, implying that our patients living with diabetes that experience neuropathy may present to other doctors other than endocrinologists. And so it is important that all of us, irrespective of our specialty, have a clear idea on how to first identify patients living with diabetes presenting with neuropathy. Bearing in mind, of course, that neuropathy from diabetes is usually a diagnosis of exclusion. On that note, I would like to welcome our speakers. For me personally, it's a great honor to introduce the first speaker. And she's a mother of endocrinology in Nigeria. She has taught many people directly and indirectly, both at undergraduate and postgraduate level. She continues to inspire many young consultant endocrinologists today and even in the future because of her simplicity, easy to approach, willingness to teach, and to continue to carry her younger ones and her colleagues around. I'm introducing Professor Felicia Anuma. Professor Felicia Anuma is a professor of medicine and endocrinology. She's the Director, Center for Diabetes Studies, University of Abuja. She's our current president for Diabetic Food Nigeria Initiative, where I happen to also be a member, and she represents Nigeria in Diabetic Food International. Professor Felicia Anuma, you're welcome. We also have joining her an astute neurologist and neuroanatomist, Professor Olabi Lukman Femi. Well, Professor Olabi Lukman Femi holds multiple degrees. He's MBBS, he has a Master's of Science, MSc in Medical Education, he has a PhD, and has fellowships both from the West African College of Physicians and from the National Postgraduate College. He's also a fellow of the Royal College of Physicians and has served in multiple professional and academic roles. He has a key interest in peripheral neuropathies and seizure disorders. He's well published with over 230 peer reviews. And Professor Olabi Lukman Femi, sir, you're welcome. And then again, as it is unique about caring for people with diabetes, one condition that requires a multidisciplinary approach is managing people living with diabetes. So to join us also is Dr. Olusola Olisheyi Adebeyejo. Dr. Olusola is the Director of Physiotherapy with Lagos State Health Service Commission, and he's also the Head of Department for Physiotherapy at the Masses Children Hospital, Lagos. You're welcome, and I would ask that we all relax, pay close attention to these eminent scholars as they share their ideas and thoughts and enlighten us on how to care for people living with diabetes and presents with neuropathy. On that note, the first speaker will start. Professor Anuma, you have the floor. With due respect, your time is 25 minutes. Hello, can you hear me? Harriet? Hello, Harriet, can you hear me?
I can hear you, sir.
Excellent. Is Ma on the call?
Her mic is mute.
Okay, let's see. Harriet, have we enabled Ma to be able to share her slides?
Maybe she can leave and join again.
Distinguished ladies and gentlemen, please bear with us. The weather is not friendly, and we know what happens to our Nigerian networks when we have such terrible weather. But please hold on, and I assure you to be very worth your while.
Okay, she's on. She's trying to share. She's already sharing.
So, hello.
Yeah, okay.
Hello.
Hello, Ma. We can hear you, Ma.
You can hear me, okay.
Yeah. So you can share your slides, Ma.
Okay. They were waiting for me.
You know, the network has logged you out.
Can you see the slide?
It's coming up, Ma.
Okay. So, can you see it?
Yes, Ma, we can. It's just for you to slideshow. Okay, no, it's on slideshow. We can see it.
So I can go on?
Yes, you can, ma.
Okay. So good afternoon, everyone. I want to thank Micronova for inviting me to this webinar to speak on diabetic neuropathy. Okay. Diabetes is a disease with, very serious complications, chronic complications. And this slide is just reminding us of, how diabetes affects virtually every organ of the body. And we know that it has become an epidemic in Nigeria. We also know that the prevalence of diabetes that we have, according to the International Diabetes Federation, 5.1%. We know that is actually not the true figure, that we have much more. The prevalence rate is much more than that. But thank God, there has been a recent national survey on non-communicable diseases by the Federal Ministry of Health. We are waiting for those figures, and I hope we won't be too shocked when we get, the true prevalence of diabetes. So diabetes is a serious disease with serious chronic complications, as we can see from this slide. But where we want to concentrate today is diabetic neuropathy. Okay. So diabetic neuropathy can be defined as the presence of symptoms and/or signs of peripheral nerve dysfunction in people with diabetes after other causes have been excluded. Diabetic neuropathy, the smaller fibers are affected first in diabetic neuropathy. With continued exposure to chronic hyperglycemia, the larger fibers become affected. Autonomic nervous system can also be affected in diabetic neuropathy. And that's the part of the nervous system that regulates key involuntary functions of the body, including the activity of the heart, the muscle, because the smooth muscles and the glands, they are also affected in diabetic neuropathy. What's the scope? The neuropathic disorder includes manifestations in the somatic and/or autonomic parts of the peripheral nervous system. The diabetic neuropathies are heterogeneous, affect different parts of the nervous system, thus present with diverse clinical manifestations and may be focal or may be diffuse. Now, the various types of diabetic neuropathy, we can have general diabetic neuropathies. For example, symmetric polyneuropathies. We have acute sensory polyneuropathy, chronic sensorimotor polyneuropathy, or autonomic neuropathy. We can have motor neuropathies affecting cranial nerves 3, 6, and 7. We can have thoracoabdominal focal limb. We can have proximal motor neuropathy. We can have inflammatory demyelinating neuropathy. Then we can have painful diabetic neuropathies, acute painful neuropathies, distal sensory, thoracic radiculopathy, lumbar nerve root plexus, and then insulin neuritis. We can have chronic painful neuropathies involving the small fiber, large fiber distal, compressive mononeuropathies, for example, carpal tunnel syndrome, ulnar nerve, or common peroneal nerve, or proximal inflammatory demyelinating neuropathy. So we can have all this occurring as a result of diabetic neuropathy. What are the risk factors? We have modifiable and non-modifiable risk factors. Modifiable risk factors like glycemic control, of course, if we don't have good glycemic control, that's a reason for chronic complications like diabetic neuropathy, dyslipidemia, hypertension, BMI, smoking, and excessive alcohol. So that's why when we take the history of these patients, we want to find out if they are smokers or if they take alcohol, so they can be advised against them, because as long as they have these behavioral issues, more complications will come. Of course, we have non-modifiable risk factors like the age of onset of diabetes. The longer the duration, the more, the complications. The height, male sex, duration, genetic factors, and then family history of neuropathic disease. Now, in the African continent, majority of foot lesions occur secondary to sensory loss as a consequence of diabetic peripheral neuropathy. So many patients have therefore lost the gift of pain and at risk of developing foot lesions. So it's interesting to know that pain is a gift. And when diabetes patients lose that gift, it can be the journey to losing their limbs. Diabetic neuropathy, some studies that have been done in Nigeria, Goya et al. In Jos in 2008, he found prevalence of diabetic neuropathy to be 75%. Olabi et al. In Ibadan in 2010 found prevalence to be 71.1%. Uloko et al. In a diabetic care, diab care study in 2008, they got 59.2%. Anoma et al. In Abuja in 2017, diabetic neuropathic ulcer as well, occurred in about 68% of our patients. And then in 2023, we are finding 80.1% of our patients with diabetic neuropathy. What's the burden? The cost to the patient and the cost to the healthcare system. Cost to the patient, of course, pain, loss of function, depression, loss of independence, and loss of earnings. Of course, if the quality of life is so low because of diabetic neuropathy, the person cannot even go to work, there will be loss of earnings. And then to the healthcare system, of course, hospital visits, the community, the growing number of patients, and then workforce and welfare system, they are all affected by diabetic neuropathy. Sadowski et al. In 2013 did a study on diabetic neuropathy patients and found out that sleep disturbance insomnia occurred in 43.8% of them, depressive symptoms in 41.1%, anxiety in 35.7%, work impairment in 43.6%, activity impairment in 52.3%, mean analyzed total direct and indirect costs per subject were $4,841 and then $9,730 respectively. So we can see the impact of diabetic neuropathy. It is a serious business. Now, pathophysiology of neuropathic pain in diabetes, the mechanisms of peripheral neuropathy, the polyol pathway activation, protein kinase C activation, oxidative stress, polypolymerase activation, alteration in neurotrophic factors, advanced glycation, end product formation, essential fatty acid abnormalities. So the polyol pathway, normally the glucose metabolism goes, if maybe my right side now, if you look at the right side on the slide, that is how majority of glucose through hexokinase is converted to glucose 6-phosphate. But when you have hyperglycemia and you have so much excess that overwhelms the hexokinase pathway, it comes through the aldose reductase pathway, and a lot of glucose is converted to sorbitol, then sorbitol converted to fructose by sorbitol dehydrogenase. All these reduce the amount of taurine and myoinositol in the nerves. That's one pathway. Protein kinase C activation with hyperglycemia, results in diacylglycerol formation. Protein kinase C is activated, and then you have vascular and neural dysfunction and degeneration because of that. Oxidative stress, excessive hyperglycemia, increased reactive oxygen intermediates, and impaired antioxidant defenses. That leads to excessive oxidative stress. and this results in vascular and neural dysfunction and degeneration. Advanced glycation end products, non-enzymatic reaction of excess glucose with proteins, nucleotides, and lipid results in advanced glycation end products that may have a role in disrupting neural integrity and repair mechanisms through interference with nerve cell metabolism and axonal transport. So, vascular. There are vascular abnormalities observed in patients with diabetic polyneuropathy, and these include basement membrane thickening, endothelial hyperplasia and dysfunction, increased expression of endothelin, which is a vasoconstrictor, increased levels of vascular endothelial growth factor. All these occur in diabetic polyneuropathy. And there's also what we call microangiopathy, and that's alteration in the nerve blood flow. We have Schwann cell dysfunction as a result of primary demyelination, secondary segmental demyelination, remyelination, and Schwann cell proliferation. There is atrophy of denervated bands of Schwann cells and basal laminar hypertrophy. So all these abnormalities occur in the blood vessel that supply the nerves. Now, the metabolic defects damage critical cellular components. There is disruption of vasoactive agents and nerve ischemia, disruption of growth factors, axonal loss, focal demyelination and regeneration, decreased conduction velocity, and increased sensory threshold. So this is the final pathway for nerve disruption in diabetic neuropathy. Now, 10 to 50% of individuals with diabetes may have an additional potential cause of a peripheral neuropathy, and some may have more than one. So we have to look at other reasons. If you look at the definition that, you diagnose diabetic peripheral neuropathy when you have excluded other factors. So there are some neurotoxic medications that can actually damage nerve in patients with diabetes or anybody. Of course, alcohol abuse is another reason, and B12 deficiency, renal disease, chronic inflammatory demyelinating neuropathy, which is inherited or can be inherited, and then vasculitis. So these are other reasons why patients with diabetes can present with neuropathy and not necessarily from diabetic neuropathy. So presentation and diagnosis, our patients come with all kinds of, complaints. Heat in the legs, it's like ants climbing the legs, it's like fire and all that. So they try to, give us an idea of how they feel with symptoms of neuropathy, but this is exactly what they are trying to describe. These pictures just simulate what they are trying to describe for us. So it depends on which fiber is affected. Is it the small fiber? Is it large fiber? The small fibers, you can have numbness or loss of feeling, prickling or tingling, aching pain, burning pain, lancinating pain, allodynia, defective thermal sensation, and decreased sweating. So when the small fibers are affected, these are the symptoms that the patient can present with. When the large fibers are affected, you can have diminished vibratory perception, decreased knee and ankle jerk, decreased protective sensation, pressure, pain, hot and cold, and then diminished ability to sense position of the feet or toes. Pain is deep aching or cramping. So for sensory neuropathy, we can have both positive symptoms and negative, symptoms. So positive symptoms, sensory symptoms, tingling, band-like sensation, paresthesias, which can be spontaneous, or diesthesias, or stimulation, hyperesthesias, increased sensitivity on touch, and then hyperalgesia, increased sensitivity to painful stimuli, allodynia, non-noxious stimuli. So the stimuli that is not supposed to be painful can become painful. You can have deep burning, hotting, shooting, sharp, jabbing, electric light flashes, or nocturnal, can be nocturnal. and then at rest. So patients tell you that they can't sleep at night because their bed sheets, they feel very uncomfortable with their bed sheets. So all these are positive symptoms of sensory neuropathy. Then you can have negative symptoms of sensory neuropathy, numbness, cotton wool sensation, watering eyes, painless ulcerations, food deformities, and it can actually be sensory ataxia. So physical examination, of course, we want to check superficial pain test. We want to do light touch, deep tendon reflex, vibration sense using the tuning for position sense, and then temperature. So these are some of the diagnostic tools for diagnosing diabetic peripheral neuropathy in the large fibers. Of course, the one with the earliest way that we can detect diabetic neuropathy is using the monofilament, okay? And then checking all these points as we have enumerated here with the red dot. And if you even get one that is, positive now, that's if the patient cannot feel even one spot, then you can make a diagnosis of diabetic neuropathy because the patient has lost, protective sensation. Of course, superficial pain testing, we can use the pin and all that. And then we can check temperature using the tip therm. It's an early diagnostic instrument for diabetic sensory peripheral neuropathy. Okay, and what we find out is that there is variance in the perceiving the extent or the temperature now, the difference in the way the patient perceives the temperature. Then we use the biotensiometer, which is a digital electronic tuning fork system designed to measure the threshold of appreciation of vibration in human subjects. And it is simple and it is very accurate. Nerve conduction studies, where abnormality in 2 or more nerves remain the most reliable, accurate, sensitive, specific, reproducible, and easily standardized measure of peripheral nerve function. However, the technique assesses the function of large caliber nerve fibers exclusively. So NCS does not always correlate with symptoms and signs. It is important to know that. And the reason is some electrodiagnostic abnormalities reflect metabolic changes that are not associated with symptoms, and then symptoms and signs are not clearly associated with electrodiagnostic changes. So the diagnosis, the following minimal criteria for the diagnosis of diabetic neuropathy have been proposed. That is 2 or more abnormal evaluations from among the neuropathic symptoms that we have illuminated the last few slides, and then neuropathic signs, nerve conduction, velocity, and quantitative sensory examination. But it is important that we keep differential diagnosis in mind. Large fibers, when large fibers are affected, we should also think of diseases like Sjogren syndrome, vitamin D, B12 neuropathy, cisplatin neuropathy. Of course, if the patient has a history of cancer and chemotherapy, that will be top on the list. Pyridoxine toxicity, Friedreich's ataxia, of course, diabetes. So if you have small fiber, we also have to look at diseases like hereditary sensory neuropathies, leprosy, amyloidosis, HIV, antiretroviral therapy, neuropathy. So antiretrovirals can also cause neuropathy. So it's just to have some of these diseases in mind when we are thinking of diabetic neuropathy. We have to make sure we have ruled all these out. We have to, so meaning in the history, we have to take a good history, asking about some of these diseases. And then when it is small and large fiber, of course, cancers can cause neuropathy, hereditary sensory neuropathies, which is either recessive or dominant, and then, of course, fecal intoxication and xanthomatous neuropathy of primary biliary cirrhosis. These are important, to keep behind our minds as we are making a diagnosis of diabetic neuropathy. So what are the goals of treatment? We want to decrease pain because that's the most uncomfortable for this patient. That's why the patient has come, and that's what the patient wants that we do for him or her, that will make him happy. provide symptom relief, ultimately to prevent ulceration. Because we know, of course, diabetic foot, one of the pathophysiological mechanisms for diabetic foot is neuropathy. And then peripheral vascular disease with infection and all that. And at the end of the day, it could be the reason for the patient losing his or her limb. We want to prescribe medications when necessary, focusing on efficacy and minimization of side effects. So we want to first, on treatment, reduction of oxidative stress using aldose reductase inhibitors, alpha lipoic acid, gamma linolenic acid, and protein kinase C inhibitors. Clinical trials with nerve growth factors, not successful yet, but still hold some promise. So work is still going on. Immune therapy, antineural, neuronal autoantibodies are also being tried. So, but treatment of neuropathic pain itself, the principles are we want to educate this patient. Of course, we want to do titration slowly. Treatment should be carefully individualized, and combination therapy may be necessary sometimes to help these patients with pain. Well, you may not bother too much about it, just to show the various classes of agents and drugs that we use in diabetic neuropathy or in neuropathic pain. We have tricyclics, we have SSRIs, we have SNRIs, anticonvulsants, opioids, then we have topical applications, drugs like capsaicin, and then lignocaine, and we have injectables like lignocaine, and even sometimes botulinum toxin may be used depending on how severe the pain is. So the general measure for treating painful neuropathy in diabetes, the first thing is that we have to improve glycemic control. If we don't improve glycemic control, then we haven't started the journey. Then exclude or treat other contributing factors like, we talked about alcohol, we talked about B12 deficiency, then uremia. So simple analgesia like non-steroidal or paracetamol sometimes may help them. And of course, we need to educate, we need to explain, empathize, and reassure them. Then we need to choose drugs according to dominant symptoms. Whatever is dominating, that's we now decide which drugs will act better. If the patient has burning pain, tricyclics may help, anticonvulsants and duloxetine will be very useful. If the patient has lancinating pain, tricyclics can also be useful, anticonvulsants and duloxetine. Then other symptoms like, allodynia, plastic film. Some patients will tell you they feel like a plastic film is, on their legs and all that. So we may use, some of these drugs like ropinirole, quinine sulfate, may be used if they have painful cramps. FDA-approved treatments for neuropathic pain, we can use lignocaine patch, 5%, particularly in post-herpetic neuralgia. Gabapentin can be used, carbamazepine is approved, pregabalin and duloxetine, they are all approved for painful diabetic neuropathy. So this is just the algorithm, after failure of simple analgesics. So we can use gabapentin, pregabalin. Remember, I told you that sometimes we can actually use more than one medication, depending on how the patient feels. We can use tricyclic antidepressants, and then from there, if the patient is still not getting better, we can go through. And sometimes a stage comes, we have to add tramadol, some opioids. Okay, other treatment options, oxacarbazepine, topiramate, and lamotrigine. These can be used depending on our second-line drugs, depending on how the patient feels. And the evidences are there on the right. So challenges with current treatment, pregabalin can cause weight gain. And of course, we don't want weight gain in diabetes because that will be counterproductive to what we want to diabetes control. Duloxetine is also used as a second line, but some patients may have nausea, vomiting from there, or sometimes glucose control may become a problem. Tricyclic antidepressants can also cause weight gain, dry mouth, and constipation, and sometimes we have to be careful about the cardiovascular effects in the elderly. And then we can use opioids, but we know the problem with opioids, they can have problem with gastroparesis. Then capsaicin can be used. It's an active ingredient in chili peppers. It responds to heat, acid, pain stimuli. It's available in topical form, 0.075%. Of course, it can also be used in high concentration, but that is experimental. And it's also effective in HIV peripheral neuropathy. Non-pharmacological options for neuropathic pain, biofeedback, relaxation therapy, physical and occupational therapy, cognitive behavioral strategies can be used, acupuncture, and then transcutaneous electrical nerve stimulation sometimes can help the patients. Then emerging treatment, botulinum toxin, locasamide, neuroregenerative agents. I think this is where and alpha lipoic acid, this is where Micronova, comes in, and I'm sure we will hear much about that and its usefulness in diabetic peripheral neuropathy very soon in this webinar. NMDA receptor agonist combination therapy can be used, like we said, and then of course high concentration of capsaicin patch can be used. Then the role of neurotropics, vitamins in diabetic neuropathy. Neurotropic vitamins, especially B1, that's thiamine, B6, pyridoxine, and B12, cobalamin, they act as modulators in the nervous system, nerve regeneration and repair, reducing oxidative stress. Remember, we talked about oxidative stress. And then symptom relief, particularly pain, numbness, tingling, and burning sensations. And they can also address deficiencies that we had mentioned, but like B12 deficiency, which can worsen neuropathy. Alpha lipoic acid reduces oxidative stress and also has anti-inflammatory effect. Ioinositol, particularly myoinositol, improves nerve conduction. So these are some of the ingredients in Micronova, and so we'll hear more about it later, and we can see what these neurotropics do in neuropathy. Thank you very much.
Thank you very much, Ma, for a well-delivered lecture. Please, we would like people to use the chat room for section on question and answers to put in their questions, and questions will be at the end because we'll have a panel discussion. Harriet, is that okay by you?
Yes, sir.
Yes. So we'll now move on to the second presenter. Prof, are you ready? Harriet, is Professor Olusola on the call?
Yes, he is.
Okay. Sir, we would like you to, if you're here, to unmute and then share your slides.
Hello, Prof. Olabi.
Hello?
Hello, sir.
Yes.
It's your turn to share your slides.
Oh, okay.
It's your turn, sir. Please share your slide, Professor Olabi, sir.
Oh. Can you see my slide?
We can, sir.
Yes. Good afternoon, everyone. Let me first say thank you to Micronova team for inviting me to give this talk. I'm Owolabi Lukman Femi. I work with Aminu Kano Teaching Hospital and Bayero University in Kano. I am going to talk briefly about what peripheral neuropathy is and how to classify peripheral neuropathy. As a matter of fact, Professor Akuma has done, a lot of what I intend to present. What are the causes of peripheral neuropathy? I won't dwell too much on diabetic neuropathy. I will also talk about the mechanism behind neuropathy and clinical features. Professor Akuma has extensively also talked about that. Then I would then finalize on holistic and multidisciplinary approach to treatment, the place of neurotonics. What exactly is peripheral neuropathy? We are going beyond diabetic neuropathy now. It's a clinical syndrome that results from damage or dysfunction of the peripheral nerves, including sensory, motor, and autonomic fibers. We all know that nervous system can be classified into two: the central nervous system, which is the central axis, brain, and the spinal cord. Okay, and the peripheral nervous system, which comprises the motor, the sensory, and autonomic nervous system. So if there is a problem with this peripheral axis of the nervous system, this is what is referred to as peripheral neuropathy. Having said that, I will briefly want to take us through, I'm sure you've heard Professor Akuma mentioned times without number, large fiber, small fiber neuropathies. Now, it would be nice to know the basic constituents of the nervous system, which is a neuron. We have the cell body, and cell body, from it you have the axons that will transmit action potential to the terminal body, where it will now communicate with another neuron or an effector organ. Now, sometimes some of the neurons have myelin sheaths around them, okay? And this is very important. So when you talk about a demyelinating disease, you are talking about removal of this myelin sheath. This myelin sheath on the neuron or on the axon has a very important function. And this is action potential moving very fast by jumping over the myelin sheath, which is what is often referred to as saltatory conduction. So in case there is a problem with myelin sheath, like in a demyelinating disease, then conduction velocity will then become slow. Having said that, so those nerves that are myelinated, so those are the ones that are often referred to as large fibers. And those ones that are, some are also myelinated, but not heavily myelinated. They are thinly myelinated. And some are not myelinated at all, okay? Those that are not myelinated at all are the ones that are referred to as small fibers. Now, the large fibers, of course, the motor neurons, then you have the nerves that subserve joint position sense and vibration sense, whereas the nerve that subserve pain and temperature, they are largely unmyelinated. So they are called C fibers. So you could still have some of them in the A category, which are the A delta fibers. Now, as these nerves are now classified into A, B, and C. A are the heavily myelinated ones, B are the moderately or thinly myelinated one, and C are the unmyelinated fibers. So, so when you talk about small fiber disease, it affects the C fibers, whereas the large fiber neuropathies would affect more of A, according to Erlanger et al. Okay. Then, aside from that, we also need to know that apart from this myelination of the axons, these axons are covered by endoneurium, perineurium, and epineurium. And if there is whatever damage that occurs with any of this, determine what you, the kind of manifestations that you see in a patient. For instance, if you have a damage that is not affecting, say, the axons, and it's only affecting the epineuron, for instance, epineuron, perineurium, then this is the one that is referred to as neuropraxia, according to Seddon classification. But under Sunderland classification, you could have one, that Sunderland class 1. And sometimes you could have the axons being affected. Now, if the axons is affected, then this is what is referred to as the azonotemesis. In terms of prognosis, of course, neuropraxia is far, far better than azonotemesis. And of course, if everything is now affected, both the axons and the covering of the axon, then that is neurotemesis, and which is under Sunderland can be grouped into 3, 4, and 5. Now, having said that, there is also pathological classification of neuropathies. Okay, of course, if the myelin sheath is the one that is affected, then it is myelinopathy. If it is the axon, as you can see here, it is axonopathy. And if both of them are affected, mixed axonal myelinopathy. In another case, there is also anatomical classification, which we often use. Now, so in terms of how neuropathies tend to behave, quite a number of times it can affect a single nerve, which is what is often referred to as mononeuropathy. The cranial nerves can be affected in that case, the facial, the abducent nerve, the oculomotor nerve. Even in the setting of diabetes, this can occur. And in some cases, it can pick on just a singular nerve, like median nerve. So you have median nerve palsy, it can cause carpal tunnel syndrome. And in other cases, it could be the ulnar neuropathy that the patient would have. Radial nerve palsy can occur. Left femoral cutaneous nerve palsy, which is often referred to as paresthesia meralgia. Okay, and peroneal nerve can also be damaged. And all these nerves that I have mentioned can be damaged by way of mononeuropathy in diabetes and many other diseases. Now, but the most common of them all is the polyneuropathy. Now, polyneuropathy tends to affect the distal aspect of the nerves that are involved. And that distal aspect of the nerves will now begin to grow back proximally. So what you have in most cases will be, you have a lesion that will start from the extreme end and will now begin to rise up. Now, once it gets to the level of the knee or the mid-thigh, then the hand will also begin to peak. So this is symmetric, and this is polyneuropathy. Sometimes you could have a situation whereby you have multiple nerves being affected. Say, for instance, medial nerve is affected on the right side. Then aside from that, you have on the left side, you have radial nerve being affected. In the leg, you have like something like common peroneal nerve. So all these will come under one category, which is multiple mononeuritis multiplex, okay, or multiple neuropathies. Now, having said that, diabetic, so essentially mononeuropathy, multiple mononeuropathy, and polyneuropathy, those are the various ways by which neuropathies generally can manifest. Now, in terms of causes, Professor Akuma has done justice to the various causes, the mononeuropathy, then those ones that will cause multiple mononeuropathy, including leprosy. But diabetes is still number 2 on that list. And polyneuropathy, the most common is still diabetes mellitus. And of course, this can be categorized into metabolic, toxic, inflammatory, hereditary, and so on and so forth. Now, having said that, let's dwell more on diabetic neuropathy. I wouldn't want to speak to the definition of diabetic neuropathy as it has been talked about by Professor Akuma extensively. Okay, how common is this diabetic neuropathy? Now, we have conducted a study in northwestern Nigeria, and we were able to show that in patients with diabetic neuropathy in our population here, about 31% of them would have diabetic neuropathy. But this is based on questionnaires. Now, but we have also looked at diabetic neuropathy based on nerve conduction studies. Now, we picked on several, nerves in the body. We picked on the median nerve, we picked on the sural nerve, the ulnar nerve, and we were able to evidently show that these nerves are affected in diabetes mellitus compared to control. So I've mentioned earlier on that sometimes you have, and okay, aside from that, in addition to that, even those diabetic patients who do not have symptoms of peripheral neuropathy, if you subject them to nerve conduction study, you will still be able to find evidence of diabetic neuropathy. We have done this over and over, both here in Nigeria and in Saudi Arabia. Now, the same thing is applicable to several mononeuropathies, particularly carpal tunnel syndrome. We discovered that carpal tunnel syndrome is quite common, much more commoner in diabetes mellitus than most other traditional causes of the peripheral or carpal tunnel syndrome. Now, in Saudi Arabia, as a matter of fact, we were even able to conduct a systematic review based on a lot of the studies that have been done previously. And we also showed that in there, 39% of diabetic patients would actually have diabetic neuropathy, as depicted by the forest plot here. So having said that, diabetic neuropathy is a neurometabolic disorder, okay, which stems from high blood glucose, causing formation of advanced glycation end products. Free radicals will be generated, and that will damage the neurons. There will be micro and macrovascular complications. Nerve damage and compromised nerve conduction will then occur eventually. So it's a complex vicious web. So what leads to this neuropathy? Now, one of the mechanisms, which is quite common, is the advanced glycated end products, AGEs. What happens in that case is non-enzymatic combination of high sugar that is present in patients with diabetes mellitus with protein. It can also occur with lipid, okay? And once they come together, they form a chief base, which is a reversible relationship. Now, the chief base go ahead to form the Amadori products, but this combination on its own can generate free radicals, okay? And free radicals can also directly damage the neurons at the level of the axons, as well as the level of the myelin sheaths, as well as the dendrites. So from Amadori products, dicarbonic compounds will be formed, and at the end of the day, advanced glycated end products will be formed. So these three products are the ones that will now trigger the expression of cytokine, as well as receptor for advanced glycated end products, and leading to formation of reactive oxygen species. Okay. Now, when we say glycation, it's often referred to glycation of these three bases, which would result in AGEs being formed. Now, from this, of course, there will be microvascular involvement, and as a result of that, diabetic complications will now ensue. Now, in anybody, of course, aside from the macrovascular complications, but in line with the peripheral neuropathy, which is more of microvascular complication. So you have neuropathies in the patient. In addition to that, the kidneys would not also be affected, nephropathy, and also retinopathy. can also occur in such patients. Now, still talking about how it's brought about. In normal glycemic states, as a matter of fact, what you have is outside the cell, once you have high glucose level, through glucose transporter, glucose can enter into the cytosol. And the glucose that enters into cytosol ordinarily or normally should result in pyruvate formation with energy, with the attendant for energy formation or production. So this is the normal glycolytic pathway. Now, but occasionally or in a reduced manner, this glucose can also be converted to sorbitol. And once it's converted to sorbitol, and it will require, a reduction, it's a reduction process, NADPA to NADP, and the enzyme that is involved in that is aldose reductase. Now, from that sorbitol, further reduction can also occur to form group fructose. Now, and the enzyme that is involved in that is sorbitol dehydrogenase. Now, fructose, as a matter of fact, is highly osmotically active, and it's also a very potent oxidant. Okay, so we have these enzymes. If you can cast your mind back to Professor Anuma's presentation on treatment, you have things like aldose reductase. This is why this becomes a target point for treatment. So this is what happens in every normal individual. Okay, this pathway is called polyol pathway. But what happens in hyperglycemic states? In hyperglycemic states, there is upregulation of aldose reductase. And there is also upregulation of sorbitol dehydrogenase. As a result of that, more and more fructose will be formed. And these are dangerous, molecules, the fructose, as well as some of the products of the dehydrogenation. Okay, why are they dangerous? Because they are the ones that can now exert, oxidative effect on nerve tissue. Now, in any case, sorbitol ordinarily should also go through another pathway that will be reduced if once SDH is high. So myoinositol, which is supposed to be part and parcel of nervous peripheral nerve constituents, will now be reduced, and as a result of that, diacylglycerol as well as phosphoinositol, which is very, very important for nerve conduction, would also be reduced because of the pull towards fructose formation. Then, which then implies that you have reduction in myoinositol, reduction in DAG, and reduction in phosphoinositol. And in addition to that, taurine, which is also very, very vital for functionality of the nerve, would also be reduced. So as a result of that, the nerve tissue will lose its functional integrity. And this is one of the mechanisms by which neuropathies are brought about in patients with hyperglycemic state. Now, having said that, the pathways are much more than that, okay? Much more than the two pathways that I have mentioned, the polyol pathway, as well as AGEs. You still have exosamine pathway, you have the AGE pathway, protein kinase C pathway, insulin pathway, as well as PARP pathway. In their various forms, they result in cascades of reaction that will bring about, nerve or nervous tissue destruction. Now, having said that, what are the clinical features? I will not spend more time on this because Professor Anuma has already done justice to it. But we often talk about the fiber type, whether there are positive or negative symptoms. So it now depends on whether the large fibers are affected or small fibers are affected. If the large fibers are affected, is it sensory or motor? If the small fibers are affected, is it sensory or autonomic, as we can recollect. Now, the negative function for sensory is impaired vibration, impaired proprioception, sensory ataxia. For motor will be weakness, wasting, hypotonia, and hyporeflexia. Impaired pain sensation, impaired temperature sensation for sensory small fibers. But if autonomic nervous system is affected, there will be reduced sweating, hypotension, urinary retention, impotence. Those are negative symptoms. There are positive symptoms like in which there is exaggeration of that symptom, like paresthesias, fasciculation cramps, depending on the fibers that are affected. Sweating and hypertension can also occur. But anytime we are faced with patients with neuropathy, the temporal profile could be of help in decide exactly what kind of peripheral neuropathies we are dealing with. Okay, we look at the neurologic deficit, whether it occurs in weeks, months, years, or decades. And if it is a hereditary problem, it tends to be a chronic thing, and it will continue to go on unabated. Metabolic can occur in that manner too. Immune-mediated vasculitic or paraneoplastic neuropathies tend to go in a step ladder fashion. Then let us now focus on holistic and multidisciplinary approach to treatment, the place of neurotonics. For a successful management of peripheral neuropathy, holistic and multidisciplinary approach to the management of such patients is advised. Okay, it ranges from health education, lifestyle modification, pharmacotherapy, physiotherapy, acupuncture, podo care, surgical therapy, and so on and so forth. So all hands have to be on deck to be able to effectively manage peripheral neuropathy. Now, how do some neurotonics work? Now, one of the most important neurotonic is benfotiamine. Okay, this benfotiamine, I have shown this diagram before. I just want to make us understand where some of those neurotonics work. For instance, benfotiamine. Okay, benfotiamine can block the free radicals. It can also block. It has anti-ageist effect. Studies upon studies have shown that it also has adult reductase inhibitory effect. It can also inhibit SDH and so on and so forth. But alpha lipoic acid, which is also a neurotonic, can also do the same, particularly blockade of advanced glycated end products. It can also block the free radicals, and it can also in a way work on SDA, sorbitol dehydrogenase. So if you look at these mechanisms, the two mechanisms that I have shown on my slide, so benfotiamine and alpha lipoic acid theoretically should be able to work against either the development of peripheral neuropathy or treatment of peripheral neuropathy. Now, if you look at it further, this benfotiamine, which is a potent anti-ageist and potent antioxidant, can help protect the nerve. Aside from that, alpha lipoic acid, which is also a potent anti-ageist and potent antioxidant, also does the same. Things like mecobalamin is a nerve rejuvenator. Studies have shown that it helps with repair of nerves. Inositol, as we have mentioned earlier on, is a key component of nerve structure, and this can also help with repair of the damage to peripheral nerve. Now, pyridoxine tends to prevent lipid peroxidation, and it can also do the same. Now, animal studies have shown this over and over. I don't want to bore us with studies on animals, but animal studies have shown. But aside from that, there are so many other clinical human studies that have also shown this. A vivid example of this is BENDIP study, benfotiamine in diabetic polyneuropathy, which is a randomized, double-blind, placebo-controlled clinical study. Now, in that study, what happened is that this got 40 participants randomly, and then they randomized them again into placebo group and benfotiamine group, and gave the benfotiamine group 320 milligram of benfotiamine. And the outcome measures were pain intensity, neuropathy symptom score, neurological disability score, safety, and tolerability. Now, and they were observed for 3 weeks. Now, following that, the key findings were that benfotiamine group showed a significant reduction in pain scores compared to placebo. There was improvement in the BFT group compared to the placebo group in neuropathy symptom score. And benfotiamine was well tolerated with no serious adverse effects. So the study was only for 3 weeks. So later it was then extended. Another BENDIP 2 was done. In fact, as a matter of another BENDIP 3 was also conducted. And all these showed similar findings in terms of efficacy and effectiveness of benfotiamine. Now, how about alpha lipoic acid? A lot of studies have also been done on alpha lipoic acid. But I would want to show a meta-analysis that aggregated, that pulled all these studies together. It started with around 512 studies, and they concluded on 10 studies. And so 10 studies were included in the after exclusion criteria, and inclusion criteria were met. Now, but the thing is that it was, you see here, if you look at this diamond-shaped, effect size, you see that oral alpha lipoic acid is favored more than placebo in patients with polyneuropathy. Now, having said this, I would want to conclude by giving us a few take-home messages that peripheral neuropathy requires a multidisciplinary, patient-centered approach, and neurotonics play a key role in nerve metabolism, protection, and repair. And early identification and management are key to the management of peripheral neuropathy. And integration of care across specialty is very, very essential. Thank you so much for listening to my talk. Thank you.
Thank you, Prof. Fantastic presentation. Thank you very, very much. Quite enlightening. I think we've now understood that there's a need to know your neuroanatomy well and understand areas where drugs will function well. Thank you very much, Prof. Again, we are now going to go to the next presenter, Dr. Olusola. I hope I got the name right. He's a physiotherapist. We would like to hear from you, sir. Are you ready to share your slides?
You kindly help me share. I already sent to Harry.
Okay, thank you, Ma. Harriet, do we have Madam's slides so that we will help her share?
Yes, we do.
Okay, Ma, we're listening. We're ready to learn from you.
Thank you so much. Thank you, Microlabs, for the privilege. And I hope everyone will get one or two things as takeaway today. All right, let's go. My outline, has the definition, will not dwell so long, the epidemiology, etiology, the types of nerve damage or injuries that we have. So I'll be talking on the physiotherapy perspective of it, of neuropathy. Now, treatment options we have, and as a physiotherapist, we are more preventive, and we'll say prevention is better than cure. So that also will be part of the outline. Now, neuropathy generally is referred to damage or a dysfunction of one or more peripheral nerves, and this can result in a variety of symptoms depending on the type and location of the affected nerves. Yes, please. And this is a picture of a nerve. Good enough. Prof that just spoke now had given us a pictorial view of a nerve and how they collaborate with the next nerve and next nerve to send signals or sensations. So where they form their synapse, the nerve, the junctions, and then connect with the next one until the sensation is sent and a motor action occurs. And so here we have the nucleus, the neuron, and the myelin sheath, because there are two types of nerves, the myelinated one and the unmyelinated nerve. Next slide, please. Now, we have, as a physiotherapist, because I'm going to do more of a mechanical thing here than systemic. So we have our spine running from the cervical down to the sacrum. We have the cervical, there we have 8 nerve pairs, the thoracic, 12 nerve pairs, the lumbar, 5 nerve pairs, the sacral, 5 nerve pairs, and then the cauda equina, which we call the tail. And then, you know, the spinal cord that spans through the length of this spinal vertebrae. And here also, we have each vertebrae, the vertebral bodies in between them, and all forming a component of the spinal vertebrae. Next slide, please. So for epidemiology, like it's been said earlier on, we, you know, Nigeria, we hardly keep our data. There is a scarce or deaths of such on the part of mechanically induced peripheral neuropathy in Nigeria is limited. But yet, in my clinical experience, it's been a frequent occurrence that patients come in, you know, people will not come in, or patients won't come in to complain until there is pain, especially pain that is limiting. Next slide. So the etiology, that's causes of neuropathy that are based on origin and the mode of injury. As a physiotherapist, I want to draw, like I said, on the mechanical origin more. So we have trauma-induced, where there is a fracture or a blunt force or a crush injury. Could have compression. Compression here, we could be talking about radiculopathy, where, like we had said earlier on, tingling sensations could happen. We say the muddy feeling, or it could be something hot or cold feeling, even where there isn't anything under the person's foot or on the leg. So aside that, once you are able to eliminate other parties, you could link it to a compression of the nerve along the spinal vertebrae. That's why I had shown the picture of the spinal vertebrae earlier. And there's that of the systemic origin, which the true profs had dwelt very much with. That is the metabolic, especially the diabetes mellitus. And we have that of infectious origin, HIV, leprosy, hepatitis B and C. Then also we could have that of as an autoimmune, an example as Guillain-Barré syndrome. And we could have such from toxic or drug-induced as side effects of some drugs. Also, it could be from cancer, that's a paraneoplastic. And then the one that we have, our micro lab here with the Neurotronics. Yes, when there's a nutritional deficiency, and even some drugs could lead to deficiency, and also could be some form of malnutrition. So these are some of the examples of the etiology, or that's the causes of neuropathy. Next slide, please. Now, I said earlier on that there are types of nerve damages or injuries that can happen to nerves. According to the classification of Seddon's classification, Seddon's classification, we have, sorry, my slide, okay, I'm back. Okay, Seddon's classification, we have neuropraxia, axonotmesis, and neurotmesis. So for neuropraxia, the definition is that there is a temporary block of nerve, and this is a mild form, whereby there's a compression, either due to a tightness, like you have tied a tourniquet. If the tourniquet is there for a longer period than necessary, it can affect the nerve around that area. And this is usually mild. And the myelin sheath around the nerve is not damaged. And recovery is usually in few days or sometimes in 2 weeks, depending on how severe the compression is. And especially if the source of the compression is being dealt with, it recovers fully in days or few weeks. Then we have axonotmesis. Here, the axon, that is part of the neuron, as I showed earlier on. The axon is damaged, but the connective tissue remains intact. And then there is a Wallerian degeneration that is distal to the injury. Every other part distal to where the axonotmesis of the nerve injury had occurred will also be affected. Recovery can take weeks or months, depending on severity and then treatment options available and how early the person presents for treatment. Then we have neurotmesis. Neurotmesis here is a complete nerve severance, whereas it includes both the sheath and the axon. So it's an example of a laceration. Laceration can be an example of neurotmesis, whereby there's a complete severance of the nerve, and there the axon, the myelin sheath, they are being affected. The recovery here is very poor, and most times surgery will be needed. Next slide, please. And now, these are the mechanisms of injury for peripheral nerves. Like I said, the neurotmesis example is laceration. You can see a total severance along the axon, and then the compression, where there could be inflammation around it, causing the space where the nerve is occupying to be restricted. And then there could be that of a stretch, like it occurs in brachial plexus injury, obstetric brachial plexus injury, where the brachial plexus is being stretched while trying to maneuver a baby out of the pelvis. So these are examples of where we have the normal, the above picture is the normal neuron. And can we mute ourselves? There's some background noise, please. All right. So the above, the topmost nerve, that is a complete normal nerve without any injury. The second one is compressed, and in being compressed, there's also an inflammation around it. This is going to affect its sensory activities. Then the next one, the sheath is lost, and we know the myelin sheath is also part of what helps in sensing our sensorial activities, or the sensations, or the stimuli as the case may be. And the last one here is a disconnection. It's been disconnected, there is a transection, a severance in the continuity of the neuron. Next slide, please. Now, for when we want to talk about radiculopathy, like that's in the lumbosacral region, when we say, okay, somebody has lumbar spondylosis with radiculopathy or radicular pain, as the case may be. Well, I showed earlier on that the spinal vertebrae, and these pictures are showing the spinal vertebrae, one each. Here we have the spinal cord going through the canal, and we have the disc annulus and the nucleus pulposus. The next one is showing where there's been an injury. It could be due to overuse or a trauma, and this has led to that fluidy thing called the nucleus pulposus to have escaped, and is escaped and is going to solidify and form osteophytes. And in this, the spinal nerves that are offshoots of the spinal vertebrae is going to be compressed. That's an example of a nerve compression, which will lead to a radiculopathy. Next slide, please. Yeah, treatment options. As we have said, the different types of nerve damages and how they can occur. We have our conservative management, which is regular, like you want to use the infrared lamp, you want to use hot or cold pack, you want to do your shortwave diatemy, or you want to use your transcutaneous electrical nerve stimulation, TENS, popularly called TENS, or then you want to do some spinal manipulation. Spinal manipulation takes a very trained hand to do this and to do safely so that you don't go compressing on the cord. And there are some exceptions to spinal manipulation. If there's a fracture or if there is a caudal equine compression, it is a no-no to spinal manipulation. And even spinal manipulation in postmenopausal women is not allowed, because their bones are brittle and it's prone to fracture, so that you don't compress another nerve or even the cord and cause more. And even in cases of neural canal stenosis, spinal manipulation is not allowed. So these are things that you would have had to assess and then tailor the patient's treatment as based on assessments findings done from the assessment. And then acupuncture, they could do the dry needling, whereby they follow the nerve pathways to block out pains and to ease off or free where there is compression to nerves. And like I said earlier on, the surgery in cases of fractures or stenosis. Next slide, please. Prevention, which is very key, because as some of those things, when they happen, we always say it, like degenerative diseases, they are not curable. You want to manage them so that they don't affect your quality of life. You want to manage them so that you can still keep going. And I will use the analogy, if your shock absorber also is bad, it is either you remove it totally or you want to keep managing it, it can't give you the very desired effects. So prevention is really key. So one of the ways of prevention is avoiding sedentary lifestyle. Sedentary lifestyle is, like they said now, that sitting for long is the new nicotine, as it is believed that nicotine is very dangerous to the health, the cardiovascular system. So also sedentary lifestyle. Now that everybody after the post-COVID era, you now know that we can actually work from home. Gone are those days, even if you have to work on your system, you still have to go to work, move out in the morning, drive your car, or walk some distances to work. But now, right in the morning, you can even work from your bed. All of this does not allow movement, as movement is health. Movement is medicine. So avoidance of sedentary lifestyle. Now, also, you can do avoidance of weightlifting. Weightlifting without proper precautions. We aren't saying you should only lift weights. You can lift objects, but you have to lift it with proper precautions. Like we always say, if you want to lift from bending down, you don't bend over your back. You bend your knees and keep your back straight to pick objects. And there is a need to pick objects or lift some weights. If the weight, like we say, if it's more than 10 to 30% of your body weight, it's advisable that you break those weights into smaller objects, smaller pieces, and carry safely without compromising your back. Then work adaptation. Work adaptations, we advise that when we sit down, we don't slouch. When we sit upright at 90 degrees. We don't slouch our backs. We don't sit on seats that have chairs that have no backrest. All these, they look aesthetically good, but ergonomically, they are not good for our backs. So we have to adapt our workstation, not just for our backs alone, to avoid lumbar spondylosis with radiculopathy or radicular pain, even our cervical region. When we are working with our systems, the laptops or the computers, our eye level should be at 90 degrees to the screen, not bending over to see the screen. Your eye level should be 90 degrees to your screen, such that you don't have to strain on your cervical region and then straining the muscles before you now come up with muscle spasms. If this is not addressed, as pain is an indicator of something going on wrong. So if you don't now attend to it, it keeps progressing and you now come up with a reduction in disc height. When there's a disc reduction in your disc height, the vertebrae over collapses on the one under, and the spinal offshoots, the vertebrae gets to rest on them, and it starts sending uncontrollable sensations to either the upper arms, as the case may be, or to the legs. Next slide, please. And the place of vitamin Bs that we have said could just be it, but like I've said, when the radicular pain comes, when the radiculopathy is there, the best thing is to seek help. And as we have said earlier on, it's multidisciplinary, and then prevention, as some of them also have multivitamin deficiencies, our postures. These are all things we can do without, and when they are present, we seek the right help at the right time so as to prevent further damages that could be permanent. Thank you for listening.
Thank you very much, Madam, for a wonderful, insightful presentation. I'm sure that while you were presenting, a lot of us were positioning our sitting to make sure we're at the right posture. And for those using their laptops, I'm sure you had to carry it up a bit to make sure that your eye level was at 90 degrees. But again, an interesting aspect to show that in managing neuropathy is a multidisciplinary approach. And of course, we got some key points on certain contraindications to physiotherapy manipulations. Having said so, I think we've had a wonderful time on this webinar. We started with Professor Akuma taking us through diabetes, the etiological factors, and then, of course, management approach. And then, of course, we had Professor Olufemi, the neurologist, that looked at the neuroanatomical aspect and looked into a greater details in anatomy and showed us points for therapeutic intervention. We've now had a good look at the physiotherapy aspect in management of patients with neuropathy. So it's been interesting. We would now like to break into the panel discussion. We have questions on the charts, and I'm going to address each of the speakers. We're going to start the way the presentations were done. So Professor Akuma, ma, I don't know if you're still with us, ma.
I'm here.
Yes, ma'am. Ma, there are lots of questions for you. I don't know if
Is
you
that
can.
so?
Quite a lot. Your lecture was eye-opening. So, and they're interesting questions, ma. I don't know if you can look at the Q&A section, or would you rather I read them out for you?
Okay. Read them out.
Okay, ma.
You can read them out. What? I will just jot I will jot them down.
Yes, ma'am.
And then I'll answer all of them together.
Yes, ma'am. So I will just go to the first one. The first question was asked. The first question was, is there a definitive treatment for peripheral neuropathy?
Definitive, okay.
Yes, but definitive treatment for peripheral neuropathy. The second question was asking about scent leaves. Ephenerin, I don't know what that is. Ephenerin.
Scent leaf.
Yes, but is there a role for the use of scent leaf in the management of peripheral neuropathy?
Oh, okay.
And then another interesting question, ma. This question says, is there a risk of vitamin B toxicity in prophylactic treatment of peripheral neuropathy?
B what? Is it B vitamins?
Yes, ma'am. B vitamin toxicity. When you use it as prophylaxis, if there's a risk for toxicity. And then finally, can I go ahead, ma'am?
Yes, please.
Okay, ma'am. Another question here says, if a patient has good glycemic control, but still has recurrent peripheral neuropathy, will they benefit from a combination of gabapentin and pregabalin? Are you with me, ma'am?
Yes, I am.
Okay, ma'am. So that was it. I think the other question would be for the second presenter. So, ma, those are your questions.
Okay. Okay. Thanks very much. I mean, it shows that they were listening when I was presenting. The first is there a definitive treatment for peripheral neuropathy? Well, I will say we manage peripheral neuropathy, but no definitive treatment as such. You treat if you can find the cause. Now we are talking generally about peripheral neuropathy. If you can find the cause, you treat the cause. But for diabetic peripheral neuropathy, we enumerated, depending on whether it is small fiber or large fiber that is affected, depending on the symptoms that the patients present with, the category of medications that we can use, first line, second line. Of course, the height of it all is to make sure that what is causing the damage is, taken care of, and that is the blood sugar levels, that the patients get a good control. So we have first line, we have second line, we even have third line drugs. So it depends on the stage you find the patient and the response of the patient to those drugs. But usually we start with the first line drugs. Some of them get better with the first line drugs. And then, very importantly, sometimes some of these vitamin deficiencies can worsen the symptoms. So if we identify particularly these neurotropic vitamins, and we replace the deficiencies, they also get better. Then the next question is about scent leaf. Well, I don't know. I'm not aware of any study that has been done on scent leaf as far as that neuropathy is concerned, or diabetic neuropathy. I haven't come across such studies, so I won't be in a position to make a comment concerning whether scent leaf is useful for diabetic neuropathy or not. But scent leaf is what we use in our soups, quite often. So I really can't say about its specific use for diabetic neuropathy. Now, that is there a risk if we give vitamins? Is there? Of course, there's a risk for toxicity if you give vitamins for prophylaxis and you are not monitoring the levels. For example, we know that our patients who are on metformin can develop B12 deficiency. So when they come with symptoms of neuropathy, we want to check what their B12 level is. If it is low, then we, of course, replace to normalize the B12 level. But any vitamin at all that is being taken for prophylaxis, if the person is taking XX, toxicity can actually occur. Then if blood sugar is controlled, blood sugar is good. You know, it depends on the stage you are getting the patient. If you are getting the patient when there is total nerve damage, because a stage comes where there is no reversal. So if it is acute, you may be able to reverse with good blood sugar control. But if the nerve is totally damaged, even with good blood sugar control, you may not be able to reverse the damage that has occurred. And we would rather prefer that you use, you know, just like when we are treating diabetes with oral medication, we say you use one class, you go from one class to another, or when you want to combine, you combine from different classes so that you can have a synergistic effect of different mechanisms of action. So I would rather that if you use first line drug and the patient is not better, you can go to second line, okay, from a different class so that you can have advantage of the different mechanisms of action to take care of whatever symptom that that patient has. Thank you. I think I have addressed my own questions.
Yes, Ma, you've addressed them very, very well. The next set of questions is for Professor Olabi. Professor Olabi, sir, are you still on the call? Professor Olabi, are you still on the call?
Thank you. I just jotted the questions.
Yeah, his mic is mute.
Yes. Sorry, I have an unstable internet connection.
Sorry, sir. Okay, sir, there are some questions for you which we would like you to address. May I read them out, or you'd rather go to the chat, question chat, and look at them? Which would you prefer, sir?
You can give me the question. You can.
All right, sir. So
if
let's
you
start.
don't mind.
Yes, sir. So the first question for you, if you can just jot them down and then answer all at when you're ready.
All right.
Excellent. So the first question for you is, the person is asking that what makes the sensory symptoms positive or negative? So he is aware, or she is aware, that the symptoms may be positive or negative, but would like to know the difference between the two.
Okay.
The next question I chose for you, but it's a general. It talks about, though Prof. Anuma answered this, it talks about what are the non-pharmacological treatment of peripheral neuropathy. I think that has been answered. So let's go on. The next one for you, sir, is could long-distance drivers be at risk for compressive nerve injury?
Okay.
Yes, I'm sure even the physiotherapists will have something to say about that. And then final question for you talks about drug usage, though Professor Numa could also have answered that. It talks about what is the duration of the usage of most of the drugs we use for neuropathy. So a patient has neuropathy and you're using the drugs.
All right.
All right, sir. Please go ahead, sir, and answer.
Oh, okay. Yeah, thank you so much. And thank you for all the questions. Let me start by saying one or two words about combining gabapentin and pregabalin in patients with difficult to manage peripheral neuropathies. I'm sure we are aware that the two classes of drugs belong to the same group called gabapentinoids. And the way they work on the same alpha-2 delta voltage-gated calcium channel. So to a large extent, sometimes it may be therapeutic duplication. Okay, it may amount to therapeutic duplication. But what we usually do is to start with monotherapy is because these are originally anti-seizure medications. Okay, you have a lot of things about them, drug-drug interactions, you have a high number of adverse events or side effects, and so on and so forth. So what we normally do is to start one and optimize that one. Monotherapy is the mainstay of this management of peripheral neuropathy. So you optimize it. If it's not working for the patient, then you add another one. Meanwhile, you start reducing the first one, if possible. Yes, they may have a little bit of synergistic or additive effects, but then the side effects, going by the side effect profile of both drugs, the patient may suffer from those side effects. Now, my own question, positive or negative symptom? What makes a symptom positive? What makes a symptom negative? If you look at the series of symptoms under positive symptoms, these are symptoms that have increased activity. When you have increased activity in a patient with respect to peripheral neuropathy, that is positive. And if it is reduced, then it is negative. Now, take for instance, numbness. That's a reduced symptom. Numbness, inability to feel, is a reduced symptom. But if you have things like cramp or hyperesthesia, that's an increased symptom. So that's a positive symptom. I hope that is clear. Could the long distance drivers be at risk of neuropathies? Yes. Particularly if the driver concerned is at risk of, say, disc prolapse or spondylosis. Now, because of the posture or prolonged stay in one posture, they are also liable to developing disc herniation. They can develop spondylosis, lumbosacral spondylosis, cervical spondylosis, and these can compress the roots of the nerves, and those are radiculopathies. Okay, so they stand, by way of their occupation, we stand the risk of radiculopathy. For how long do you use some of these drugs, be it the anti-seizure medications or neurotonics? This would depend largely on the severity of the neuropathy. It will depend on the severity of the neuropathy. It will depend on the type of the neuropathy you are dealing with. Okay, but quite a number of times we try to tailor the drugs in terms of the duration that we will place the patient on that drug for to the symptoms that the patient have. I think these are the questions that I have.
Thank you very much, sir. Thank you so much, sir. Very well answered. Dr. Shola, are you still here?
Very well, yes, thank you.
Excellent. So we have some interesting questions for you.
Okay.
I think the main one would be, what is the rate of improvement of patients with peripheral neuropathy who undergo physiotherapy?
Okay. Okay.
And there is another one here, just a minute, let's see. This other one talked about, well, you've answered that. The person was just asking about the role of physiotherapy in managing neuropathies and precautions to take. I think you did that in your presentation already. So you may answer that single question, ma'am. Thank you.
All right, thank you. Well, I guess the first question is more on prognosis, how well the person does. As with every case, severity is one, and also early presentation. Like the first Prof said, if the nerve has already been damaged, fully damaged, we had described the types of nerve damage, if there's a neurotemesis, azonotemesis, or neuropraxia. So if there's a full laceration, a full severance, that's the person will have to go for surgery first before commencing physiotherapy. If at all physiotherapy is still being done, it's going to be palliative just to relieve the pain. But when pain will not be relieved by physiotherapy techniques, then surgery first then physiotherapy will now commence after the surgery has been done. Where physiotherapy now comes up after surgical intervention is, during the surgery, the muscles are going to shut down because of pain. There's going to be inflammation. And then because of there'll also be some effects of neuropraxia as well from surgery and inflammation. Then the nerves too, you now have to start working on them to come back to re-educate those muscles that have been cut open for surgery to take place. And then the pains that have been there are not going to go immediately. Don't forget every other part distal to that part that the nerves were supplying would have pain. I now have to work on the soft tissues, the joints, and then aid mobility. You even have to start like you are teaching the child how to walk. I remember then in school, Prof. Once he has done laminectomy for his patients, he will come and say, physio, please come and walk my patient. Because now I have to start with sitting them out of bed, to standing them, and then being able to educate them to walking and then back to their full life. What the surgery would have succeeded in doing is to disengage the trapped nerve or fix back the lacerated nerve. In some, there are microsurgeries whereby they have to take a nerve from a part and transplant. And when you have to do such, you have to train that nerve to do what activity is now meant to start doing, because it wasn't meant for that purpose. So you have to re-educate. That's why the word re-education will come. So prognosis depends on severity, early presentation for management, and then some other comorbid issues. If the person is diabetic, and those are, and especially when it is uncontrolled, that could be a factor also for prognosis, for healing to come and be very effective. So also is age. Somebody who is well advanced in age, the muscles aren't going to be as strong or well toned like someone who is in the 40s or 30s or 20s. So all of these, they contribute to the healing rate or the effectiveness of therapy sessions being done. I hope that answers the questions.
It does, I think. Very well answered, very detailed, and I think it serves its purpose. On the chat box, I just saw a question from the neurologist in my department, Dr. Ernest Wanzo. He's talking about laser therapy in the treatment of peripheral neuropathy. I don't know which of the presenters would want to take that.
I think physiotherapists too do use laser.
Yes,
we do laser therapy as a motor point. You direct it at the very point where the pain is. But with time, some of those things, you can't use them singly. They are used as an adjunct. So if you are going to direct the laser beam on that spot, on that nerve, but if it is a compressed nerve, you have to work on decompressing. Yes. So whatever doing laser is going to be palliative, just treating symptomatically. You are not treating to the very root cause of the radicular pain or radiculopathy.
Okay, thank you very much, Ma, for that. I don't think I'm searching to see if we have other questions. I'm searching to see. I think we have answered all the questions. So, Dr. Harriet, I think that the floor is back to you.
Prof, I can still see some questions.
Where are they?
It says here, please,
okay, I've seen one.
Okay, you've seen.
Yes, there's what I'm seeing here. Thank you for the presentation. Please, is there a set value for commencing or discontinuing neuropathy medications via the glycated hemoglobin in diabetes mellitus? And then which class of drug is superior for FM? I don't know what the person means by FM neuropathy. Okay, focal neuropathy. So I think Professor Numa, I don't know if you would handle this. Ma, are you still on the call?
Hello.
Yes, ma. I would like you to take this question, ma.
Which one is that?
It's a question talking about is there a value for continuing or discontinuing medications for neuropathy? That is, the person is looking at HbA1c value. Is there a value that the patient will attain with their HbA1c that will determine whether you should continue or discontinue?
It is if the person listened very well to the presentation, there are situations, it's not the HbA1c value that determines whether you use a medication for neuropathic pain or not. It is the symptom the patient is presenting with. And there are people, like I said, it depends on the extent of the damage, which the physiotherapist also alluded to a while ago. If the nerve is permanently damaged, even if you now achieve a good control and your HbA1c is 6%, that now has no relationship with what the patient is presenting with. The patient is presenting with now symptoms of nerve damage, and you have to take care of that. So it's not related, the length of treatment is not related to HbA1c level. It's not related to glucose level if the damage is already done. But of course, if we have excluded every other cause and we have concluded that it is diabetic neuropathy, one of the very first things is to even control the glucose level so more damage does not occur. So it's not really the HbA1c level that determines what you do. It is the symptom the patient is presenting with that determines what you do.
Okay, thank you very much, Ma, for that. Harriet, I don't know if there are other questions left.
I'm actually seeing what is the target for glycemic control in diabetic mellitus neuropathy. I'm also seeing does capsaicin offer morbidity benefits?
Okay, so I think the one for the glycemic control and targets, I think Professor Numa has answered that. So for the question on capsaicin, I think we would allow Professor Olabisa. Can you take that question, please?
Sorry, can I have the question again? Sorry.
Is there a question?
Harriet, could you, because I can't see it.
Also, does capsaicin offer morbidity benefits? Yes, capsaicin.
Whether capsaicin is beneficial in the management of peripheral neuropathy.
Morbidity benefits.
Yeah, capsaicin is beneficial in painful peripheral neuropathy, generally, by virtue of the mechanism of action. In fact, a lot of studies have compared capsaicin with pregabalin as well as gabapentin. And capsaicin has been found to be useful in the management of painful peripheral neuropathy. Thank you.
Thank you. So I think that's about it. I can't, Prof, I don't think I have more.
I think the problem was some people were putting questions in the chat rather than the questions and answer section. So, but I've said, I don't think there's anyone, so I think we can go on.
Okay.
So Harriet, I think it's over to you. Vote of thanks, it's up to you.
So my BDM, Dr. Joel, who will take over the next session.
Okay, thank you. On behalf of Micronova, thank all our speakers and also to our moderator, Professor Korubo. Very big thank you for the wonderful moderation and the sessions. Just as a way of reminder or way of reintroduction, this webinar was put put together with Micronova Forte in mind. Micronova Forte is an antioxidant fortified nerve rejuvenator containing benfotiamine, which is a lipid-soluble vitamin B1 form, thiamine form. And then, of course, alpha-lipoic acid have been spoken extensively during the course of this presentation and is one key agent in Micronova Forte. And following up is inositol, pyridoxine hydrochloride, and mecobalamin, which is vitamin B12. And of course, deficiency of vitamin B12 has been shown to have its negative impact on nerve function. So these agents were well put together in Micronova Forte to prefer level of support and adjunct therapy in the management of peripheral neuropathy, whether as resulting from diabetics, alcohol use, deficiency of B vitamins, aging, or just as a support for nerve function. So Micronova Forte is readily available from us, one capsule twice daily, recommended dosing for Micronova Forte. Maintenance dose is one capsule daily. But want to thank all our guests for being a part of this webinar, and also once again special thanks to erudite speakers who had done justice to this subject of multidisciplinary approach to the management of peripheral neuropathy. This webinar is recorded, will be made available to all participants through email addresses used for registration. And then, of course, for those who will be requiring CME points, CME points also will be awarded to participants looking at the duration you have spent also during the course of this webinar. The analysis will be done, and then the CME points will be awarded. So on behalf of Micronova, I want to say a very big thank you for the time spent, quality time spent for this discourse. And we believe that the points shared in this webinar will enhance various practice and, of course, improve patient care in all our centers. So once again, thank you very much for being a part of this. And we look forward to having you in our webinar series because Micronova is poised towards improving knowledge and, of course, contributing to the quality of care physicians provide for patients. Thank you once again, and do have a wonderful evening. Thank you.
Thank you very much, and God bless you all.
Thank you.
Prof, thank you very much. Prof. Olabi, Prof. Anuma, Dr. Shola, Prof. Korubo, thank you very much, and all our audience. God bless you and have a beautiful evening.
Thank you. Bye-bye.
Bye.